Hello and welcome to Neurosensory Part 2 for clinical cases. Today we're going to be looking at the next 10 clinical cases that we were taught about in the neuro block of second year. So the first three diseases that we're going to look at are associated with the eye. And when we think about the eye, we think about problems with the muscles of the eye or the nerves of the eye. So the first three we're going to look at are gradual loss of vision, rapid loss of vision, and childhood eye problems. Now, first, you do need to understand the nerves and muscles of the eye, and the easy way to remember this is SO4, LR6, EE3, standing for superior oblique 4, lateral rectus 6, and everything else 3. So the superior oblique muscle is innervated by cranial nerve 4, and this depresses and abducts the eye. The lateral rectus muscle is innervated by cranial nerve 6, and this abducts the eye, so pulling it laterally. And then everything else, so your inferior oblique, inferior rectus, superior rectus, and medial rectus are all innervated by cranial nerve 3 and all have their own roles individually. So in terms of gradual loss of vision, there's a few conditions on here that you need to be aware of. So the first one is glaucoma, and this is due to high pressure inside the eye which damages the optic nerve, and the patient will normally suffer with intense eye pain or red eye. The next one is age-related macular degeneration, so this can be dry or wet. So dry is the most common, but in terms of wet, you'd be looking for kind of bleed or hemorrhage within the eye. Normally the patient will lose their central vision, so therefore a loss of visual acuity, and they'll also lose their contrast sensitivity, because you think that's one that's affecting the photoreceptors of the eye. Next you've got cataracts, so this is a loss of transparency of the lens of the eye. These are removable by operation, which is normally the most common route of procedure for someone suffering with cataracts. But in terms of symptoms, the patient will have difficulty to see in dim or very bright lights, and they'll also have a glare from bright lights, which may make vision uncomfortable. Lastly, you've got diabetic retinopathy. So the two causes here are leaks out of blood vessels, which interfere with the light transmission, or ischemia, so reduced oxygen, reduced circulation. Okay. Moving on, we've got rapid loss of vision, and again we've got a few conditions here to be aware of. So retinal vein occlusion, this is a blockage of the small veins that carry blood away from the retina. The causes of this are usually high blood pressure, high cholesterol. You can also have retinal artery occlusion, so therefore you lose whatever part of the retina that artery is supplying, because without the blood supply it can't function. You've got ischemic optic neuropathy. So this is when blood does not flow properly to your eye's optic nerve, and this can cause lasting damage to the nerve and therefore to the eye and the vision of the patient. You've got vitreous haemorrhage, so this is where your vitreous should be clear on a normal day, but it's not. You can see in the picture just to the right hand side here of the bleed and how that's affecting the clear vitreous humour. Moving on, you've got retinal detachment, so this is where your retina peels away. The macula is still attached though, so you lose your peripheral vision but keep your central vision. And lastly, you've got acute glaucoma, so this is a gradual damage to the optic nerve or rapid damage to the optic nerve. Okay, but really with glaucoma you're thinking about damage to the optic nerve. And lastly, in terms of eye problems, you've got childhood eye problems. So one that as a doctor you should never really miss is leukocoria or white pupil, and it's the commonest cause of this is retinoblastoma, okay, which is a malignant tumour. So therefore being vigilant there is really essential, because obviously you can be the difference between whether you save a child's eyesight. Refractive convergent strabismus. So this is a squint. So strabismus is a posh word for squint, and it's a condition where the eyes do not look in the same direction. So one eye may focus on one thing, while the other eye is focused on something else. And lastly, you've got retinitis pigmentosa, which is a group of genetic disorders that affects the retina's ability to respond to light. Okay, and this is a genetic disorder. So moving away from eye diseases now. Syringomyelia was a condition we were taught about in the neuroblock. So this is a formation of a cyst or a cavity within the spinal cord. And you would expect around 50% of patients with a Chiari malformation to also develop syringomyelia. Okay, so remember that Chiari malformation is a downward displacement of the cerebellar tonsils towards the foramen magnum, and therefore you'd also expect them to, at least 50% of the patients really, to develop a syringomyelia as well. In terms of treatment, it aims to relieve the pressure on your spinal cord, so the treatment is very much related to the cause, so it's cause dependent, but surgery is an option if the condition is having a negative impact on your day-to-day life. Obviously, it's to concern the spine, so therefore you're thinking about back pain, shoulder pain, arms and leg pain, and also an inability to feel hot and cold and a loss of pain sensation. So all those things that you'd associate with the vertebral column there fall into the symptoms. Next, you've got idiopathic intracranial hypertension. So if we think about the word idiopathic, we're thinking spontaneously arising condition with unknown cause. But IIH is an increase in intracranial pressure, but with an absence of a tumour. Normally, as a doctor, you would be performing a lumbar puncture and a brain scan. So lumbar puncture really is essential here in terms of providing some relief to the patient by reducing that pressure by removing the cerebrospinal fluid. This box here at the top is really important. So what is it not? It's not hydrocephalus. Yes, you've got a build-up of CSF, but it's not hydrocephalus. The ventricles don't enlarge, there's no tumour, and the brain doesn't swell, and there's also no obstruction of CSF. So therefore, it's idiopathic intracranial hypertension. But what causes this disease? It's most commonly seen in young women who are overweight, and it's normally people who put on weight rapidly. And therefore, really, when we're thinking about treatment and management, obviously we can do all the lumbar punctures and brain scans and everything like that. However, really, the key treatment or management of this condition is weight loss, and you need to lose around 15% of your body weight for your intracranial pressure to return to normal following putting on that weight. Okay. Causes then, it could be a blood clot on the surface of the brain, a subdural hematoma, it could be a brain tumour or a brain infection, but also it could be down to blood vessel abnormalities. Next, we've got cerebral venous sinus thrombosis, and this is an acute clot in the dural venous sinuses of the brain. So the dural venous sinuses are there to drain blood away from the brain and back to the heart. Risk factors of developing this condition are if you're pregnant, also head injury is a likely cause, or a tumour of the venous sinuses. Patients presenting with this complaint, you'd expect them to have headaches, blurred vision, any kind of fainting or loss of consciousness, also seizures and a coma, potentially, being worst case scenario. In terms of prevention, we can really help to prevent this by eating a low-fat diet, getting daily exercise, and avoiding cigarette smoking, all really key in prevention of a CVST. Next, we have a hematoma. So you can subcategorize these down into subdural and epidural as the main two that you need to know about. So a hematoma in general is a collection of blood which is outside the blood vessel, so it shouldn't be there. It should obviously be inside the blood vessel, but a rupture of some kind has caused this to happen. So if we think about them in a broad sense, an epidural hematoma, this is where there's arterial blood between the dura and the skull. Okay, and normally it would present in a lens shape, so these are quite characteristic. On a brain scan, you'd be able to see the lens shape of an epidural hematoma, and it's due to the rupture of a middle meningeal artery. Okay, so this is the most common with a skull fracture, so through trauma. Alternatively, you'd think about a subdural hematoma, so this is made up of venous blood, not arterial blood, so that's a key distinction there. Also, on a brain scan, you'd expect to see it in a chrysanthemic shape, so almost like a moon shape or banana shape. This is due to the tear of the bridging vein. So one key thing to remember here is what vein is affected. So with epidural hematoma, you're thinking about the middle meningeal artery. And then with subdural hematoma, you're thinking about the bridging vein rupture. Next, we have meningitis. So there are several categories as well which meningitis can fall into, with bacterial meningitis being the most severe. Meningitis is an infection of the protective membranes or the meninges of the brain and spinal cord, and these are dura, arachnoid, and pia from outside inwards. And it can affect anyone, however, it's very common in teenagers and young children. So bacterial meningitis, obviously quite self-explanatory, it's caused by a bacteria, and this is probably the most common but most severe form of meningitis. Without doubt, you'd be wanting to perform a lumbar puncture on the patient to gain a sample of CSF and test for meningitis, because it can be a fatal condition in many cases. HIV, So this is human immunodeficiency virus. This is a lifelong condition which stays with the patient. And the three most common ways of inheriting or gaining HIV is when it is passed from mother to baby through sharing needles. Contaminated blood transfusions also can be linked to sharing needles there, and also unprotected sex. It's essentially a big failure of the immune system, which leaves you vulnerable and susceptible to life-threatening illnesses. It's also linked to AIDS, so acquired immunodeficiency syndrome, and this is basically a categorization, an umbrella term for the life-threatening infections and illnesses that can happen and compromise your immune system due to the HIV virus. Okay. Last one for this video. So measles is a highly contagious infection. Of course, it is preventative with the MMR vaccine, which is given as a childhood vaccination program. It can be really unpleasant for the patient and can also lead to serious complications. There's no particular treatment, but however, you'd normally see that it improves within 7 to 10 days of developing the condition. And normally the best way to battle this disease is to take things easy and maybe take some paracetamol or ibuprofen to manage the fever that you're experiencing. The initial symptoms of measles develop around 10 days after you're infected, and these are very similar to cold-like symptoms, so runny noses, sneezes, coughs, also a sore red eyes, maybe sensitive to light, and also a fever, so a high temperature, which could reach around 40 degrees. Having said that, measles can be unpleasant, but obviously it will pass, hopefully in around 7 to 10 days without causing any further problems. And then once you've had measles, it works in a way that chickenpox does, very similar there, so your body builds up a resistance or an immunity to the virus, so therefore it's highly unlikely you will be infected again in the future. So that's everything for part 2 of Neurosensory. If you do have any questions, please let me know, or if you've got any suggestions on how I can make these videos better, that would be greatly appreciated. Thank you for listening.